and a mentor of mine, Dr. Scott Stevens. Some of you will remember that he has addressed this group before, and he was asked to return by popular demand. You will see that he is a very engaging and knowledgeable speaker. I just want to tell you briefly about Dr. Stevens. He earned his medical degree from Loma Linda University in 1995 and later completed an internal medicine residency at the LDS Hospital in Salt Lake City. He now serves in numerous roles, including the program director of the transitional year residency at the Intermountain Medical Center, associate program director of the internal medicine residency of the University of Utah, and additionally, the vice chair of the Department of Medicine at the Intermountain Medical Center, and directs one of the largest venous thromboembolism clinics in the western United States. One thing I'll tell you about Dr. Stevens, and I said this last time, is that he literally is a walking encyclopedia. Not only does he know and can quote the literature regarding DVT and venous thromboembolism, including much of our literature, better than anyone I have ever met, but he has significantly contributed to the field as well. He has served as principal investigator for numerous clinical trials and has more than 50 publications in the field. Dr. Stevens presently serves on the steering committee for the NIH-sponsored COAG and GIFT trials and the Canadian Institutes of Health Research DODS clinical trial. One notable thing is he has served as a panelist for the Antithrombotic Therapy and Prevention of Thrombosis from the American College of Chest Physicians Clinical Practice Guidelines. Let me now turn the time over to you, Dr. Scott Stevens.
Thanks very much, Steve. That was an overly kind introduction, and I won't comment on your lack of judgment by inviting me back, but hopefully I'll live up to a small percentage of the billing that you just gave me. I've done a few webinars, but the inability to see the audience is always a bit of a deficit in terms of making sure that things are getting across. So feel free to hit the raise your hand button. And I can't see hands going up on my screen since I'm sharing, but if Steve, if you could kind of interject if there's questions along the way, I'm happy to take them as we go, and then happy to spend a little time at the end as well.
Sure.
So as Steve mentioned, I had the interesting experience of serving as a panelist on the 9th iteration of the American College of Chest Physicians Guidelines. There's the full title of the guidelines displayed for you there. As you might imagine, we took to calling them AT9 for short to avoid that mouthful. I think it was Winston Churchill who said, if you like good government and you like good sausage, you should probably not watch either of them being made. And I think the same can definitely be said about evidence-based practice guidelines. It was kind of a wild ride getting these things put together. But I'm really proud of the end product, and am really happy that I was able to make a small contribution to this huge effort. As I go through the talk, I'll be alluding to the guidelines, and particularly alluding to the grades that are attached to the treatment recommendations as we hit different topics along the way. This is an overview of the grade system as it was modified for the ACCP, and actually the author of the grade system was one of the overall editors for the guidelines, and so we definitely had methodologic experts in the field. You're probably familiar with grading of evidence, so I won't go through it exhaustively, but we'll just briefly point out that the number attached to the statement has to do with the strength of the recommendation. So grade 1 statements carry the phrasing we recommend, grade 2 carry the phrasing we suggest. That differential really stems not from the quality of the evidence, but from the magnitude of effect of the statement. So if the risk-benefit balance really favors doing something that gets a grade 1, if the risk-benefit balance is tighter and the decision's more nuanced, that gets a grade 2. But different levels of evidence can support recommendations of either strength. So I'm going to take you through a whirlwind tour of various aspects of the medical treatment of venous thromboembolism. We'll cover both DVT and PE to some degree, and we'll particularly hit the issues that have to do with acute management, interruptions of anticoagulants for interventional procedures, and dealing with things that go wrong, like excessive anticoagulation. And then we'll finish up the time discussing the novel oral anticoagulants, which have had a lot of development in the last year. So the basic treatment approach for acute DVT or PE has really remained unchanged for a long period of time. There's an initiation period, which is usually thought of as the first week or so of treatment, and that's when a rapidly acting, classically parenteral anticoagulant has been given to get therapy going. A high potency and reliable anticoagulant is needed during this period because this is when thrombin's really revved up and clots are really most likely to propagate. At the same time as initiation, the acute phase treatment with warfarin begins, and both medications are given on the first day of therapy. There's not a need to wait a day between the initiation of the injectable anticoagulant and the initiation of the warfarin. So both medications are started on the first day. And then following 3 months of treatment, this is where things have been renamed a little bit. There begins the secondary prevention phase. And the idea behind this nomenclature is that the first 3 months of anticoagulation is really all you need to treat the clot you got. Thereafter, all anticoagulation confers the benefit of secondary prevention, which is to say it prevents the formation of a new blood clot. So the key decision in terms of duration of anticoagulation is deciding who's done after the acute phase and who's at high enough risk of future blood clotting that they ought to enter the secondary prevention phase. And I'll talk a little bit more about that as we go along. So the standards of care as articulated by the ACCP are to begin warfarin on day 1 along with the parenteral anticoagulant, which can be low molecular weight heparin, unfractionated heparin, or fondaparinux. And that those two therapies should be overlapped until a minimum of 5 days of parenteral anticoagulation have ensued, and until the INR has reached a value of 2.0 or higher and has been at least that for 24 hours. That last bullet has been rephrased with every iteration of the antithrombotic guidelines because some nuance of the phrasing always allows people to get out of that overlap period. And the way that AT8 was phrased, it was possible to check the INR once, and if it was above 2, check it again an hour later, and if it was still above 2, you could stop the parenteral anticoagulant and still be within the standard of care. So now they've really finally found their language and have really shown that you really need to complete that last full day of overlap after the INR has gotten into range. And this is actually one of the few grade 1 statements in the entire 89 guidelines. They got really tough on their standards of evidence. And there's very few grade 1 statements anymore, so this is one of the ones that's of key importance. The Canadians have actually studied the ramifications of failing to do this full overlap period of anticoagulation and have found that the risk of rehospitalization for progressive thrombosis doubles if you try to shortcut the overlap. So that's something I really try to emphasize as I talk about the initial therapy for DVT and PE. So as I mentioned, we have several choices for the initial parenteral anticoagulant. These include low molecular weight heparin, unfractionated heparin delivered in a variety of ways, including adjusted dose IV, adjusted dose subcutaneous, or fixed dose subcutaneous, and then the newest of the injectable anticoagulants, fondaparinux. The guidelines go on to suggest low molecular weight heparin or fondaparinux over unfractionated heparin, largely due to ease of use. The clinical effectiveness of the two groups of agents is pretty similar. This is not a new study, but I think one that's worth emphasizing. Clive Kieran at McMaster University really had an interesting idea. He came across the thought that the advantages of low molecular weight heparins are actually somewhat overrated, and that you could probably achieve the same thing with unfractionated heparin at a fixed dose. And so he did the FIDO study in which he administered unfractionated heparin, at like 4 or 5 cents a dose, according to the dosing strategy listed there for you, and did that without lab monitoring, and used that as a transition to warfarin, and demonstrated equivalent outcome in patients who were given low molecular weight heparin. So that remains a a viable option according to the ACCP guidelines. The one reservation of that study was that it was open label and not blinded, but I think still a potentially sea-changing study, particularly for patients who have low funding and need an inexpensive parenteral anticoagulant. As you may know, enoxaparin went generic over the last 18 months. Unfortunately, the price didn't drop substantially when the generic formulation came out, so it's still a very expensive treatment. So let's take a moment and talk about the treatment of DVT isolated to the distal deep veins, because I think this is a really important and emerging area that requires careful thinking about your therapeutics. By distal DVT, I mean DVT isolated to the veins distal to the popliteal, so perineal, posterior tibial, soleal, and gastrocnemius. There's been one prospective study that the Italians did that was very interesting, really looking into the idea of how beneficial it is to treat these patients with anticoagulants. So they started with a group of patients suspected of DVT, and then they took all those who had a negative proximal ultrasound, which is to say they had no clot in their femoral or popliteal systems. They then selected from that group of people those who were at high pretest probability of DVT using the Wells score, or had an abnormal sensitive D-dimer assay. That group of people, they then subjected to whole leg ultrasound, which is to say they went on to scan the calf veins. And out of those 431 people who had a negative proximal ultrasound and then went on to get whole leg ultrasound, they found 63 of them had isolated distal DVT, and 368 of them did not have isolated distal DVT, which is to say they had a negative whole leg ultrasound. Then the investigators did something really gutsy. They disguised this information from the treating clinicians and from the patients. So the status of the calf veins was unknown, and these patients were not anticoagulated. So what went on to happen to these two groups is they got no anticoagulation, but they did get an ultrasound a week later, which is the standard of care if you only do the proximal veins. In the group with distal DVT, 2 of them came down with proximal DVT a week later. Interestingly, in the negative group, 3 of them came down with proximal DVT a week later. Those 5 patients were anticoagulated, and then the remainder went on with 3 months of clinical follow-up. In the group with distal DVT, 3 more proximal DVTs developed during 3 months of follow-up. In the group with the negative initial ultrasound, nobody else came down with DVT. So there was a difference, a net difference of 3 DVTs detected by performing the whole leg ultrasound. So the upshot of this is that if you had anticoagulated all 63 of those people, you probably would have avoided those 3 extra proximal DVTs. But the cost of that would have been at least 1 major bleed based on what we know of the bleeding risk of anticoagulation therapy. So this emphasizes that the risk-benefit balance for treating distal DVT is really tight. It sits on a knife edge, and it's really worth thinking through how to treat these patients. So the 1809 guidelines have actually greatly expanded their treatment of isolated distal DVT, and they give you 2 options. The first and slightly preferred option is to not anticoagulate these patients, but rather to do serial ultrasound for 2 more weeks, 1 ultrasound a week for 2 weeks, and anticoagulate only those people who get the DVT propagating into the proximal veins. They particularly like this approach if the patients aren't highly symptomatic and in patients who are at high risk of bleeding, because obviously you want to try to avoid the risk of anticoagulation in those patients. They do and also they would suggest not anticoagulating patients with DVT isolated to the soleus and gastrocnemius system, because those patients have a very low risk of propagation. Alternatively, you can anticoagulate patients with isolated distal DVT. They would suggest this in patients who have severe symptoms, and they would suggest you consider it in patients who have any one of these risk factors that make it more likely that they might have extension of the distal DVT. But in my practice, I really favor the serial ultrasound strategy, and I would say I anticoagulate only 1 out of 5 distal DVT cases. I do serial ultrasound in the remainder, And I almost never initially anticoagulate a muscular calf DVT. And I think that that's a very rational approach to the care of distal DVT. Very low standards of evidence to apply to these decisions, unfortunately. So let's move on to the arms then and talk about treatment of upper extremity DVT. Fortunately, it's pretty simple in terms of the decision making. The treatment standards are the same as for the lower extremity. The ACCP, unlike other entities like the British Thoracic Society, do suggest a minimum duration of 3 months of anticoagulation for the arm. And they define arm DVT as the axillary and subclavian veins, and then, of course, the internal jugular. They are equivocal on the brachial vein because there's very little research attached to it. And also they point out that basilic encephalic thrombosis is superficial in nature and probably in and of itself does not merit anticoagulation. As you know, a great many upper extremity DVT cases are the result of central venous catheters, particularly PICC lines. And in a modification of the 1809 guidelines has been to explicitly state that the catheter can remain in place if it's still needed, which is to say you start the anticoagulants, but you don't have to pull the catheter if there's a DVT there. And I think that that's an extremely useful piece of information because often the catheter is in there for a reason, and it's safer to leave it in there and only take it out when you're done with it. And there's the grades of evidence for those statements. So let's talk just briefly about invasive treatment of VTE. There is the internist's picture of those gizmos you guys use when you're trying to clean out clots. Obviously, I can't hear you, so I'm assuming I got a little bit of a laugh with that statement. You guys are much more expert about the technical aspects of this than I'll be in the entirety of my career. But what I would like to do is skip a stone quickly across the clinical trials of invasive treatment and review very briefly with you the guideline statements from 1809. So let's start with pulmonary embolism and thrombolysis. We have a few pieces of information that are interesting. This, I think, is the best registry looking at thrombolysis for PE. And this was open label. The clinicians just decided whether to lyse or not, and they observed the patients for outcome. You can see that there's a surprising lack of statistical significant difference in anything in terms of outcomes in this group, most notably mortality without a statistically significant difference. The bleeding rate, unsurprisingly, trended toward favoring anticoagulation alone, but even that was not statistically significant. So in an observational study design, it's hard to tease out any apparent benefit from thrombolysis, but obviously this is a registry. There has been a meta-analysis performed of the smaller studies looking at thrombolysis for pulmonary embolism, and you can see that they do suggest a relative risk reduction in death, although that did not achieve statistical significance. Likewise, the effect on recurrence didn't achieve a statistical significance, nor did major bleeding, nor did pooled adverse outcomes of any type. So again, for meta-analyzing the small trials of thrombolysis, it's again hard to find convincing benefit from the intervention. The best RCT to date, which made it into the New England Journal, was the MAP-IT-3 study. And this looked at performing thrombolysis specifically in the population with submassive PE. So these are patients who have anatomically large PE, evidence of right ventricular strain either by imaging or biomarkers, but did not have hypotension. They then randomized these patients to receive alteplase or placebo thrombolytic. Everybody received anticoagulation, of course. They found that there was a statistically significant difference in what they called rescue lytic. And this was a very controversial endpoint. Rescue lytic meant that the treating physician decided that the patient wasn't doing very well and they ought to be lysed anyway. And so they unblinded the patient and performed a lysis procedure. Whether that outcome was really all that valid or not has been subject to endless controversy since this trial came out. But like the registries in the smaller studies, the trial did not manage to note any significant difference in mortality, major bleeding or thrombotic outcomes, and interestingly, there were no intracranial hemorrhages in that study. So as high standards of evidence go, it's kind of lacking, but at least is a study that suggests there is a potential benefit for thrombolysis. So what do the 89 guidelines have to say? They suggest that thrombolysis be considered in patients with acute PE and hypotension, which is defined as a systolic blood pressure less than 90, patients who are not at high bleeding risk, and then looking at the submassive PE group, normotensive patients who are thought to be at high risk of a bad outcome and have low predicted bleeding risk. And then they go on to point out that they suggest against thrombolysis in the majority of patients with pulmonary embolism. And you can see the frustratingly low grades of evidence on the statements there. What about invasive DVT treatment? I won't go into this at any length at all, except to say that the 89 guidelines suggest against this in most patients. They go on for a fair amount of length in the supplemental text about how to select potential candidates, and it's basically highly symptomatic proximal DVT, and particularly potentially limb-threatening proximal DVT. They do not make any statements favoring the technique for catheter-directed thrombolysis, so they don't make a stand on additional interventions like rheolysis or balloon isolation or any of the other devices that are presently out there. I will point out that there actually is an RCT going on right now, so maybe in the next year to 18 months we ought to have real RCT data on invasive DVT treatment, and that would be really welcome because everything so far has been open label registry. And then finally, IVC filters. So this is again the ICAPUR registry, and this I think is one of the most interesting observations to come out in the last few years. They, again, had open label intervention. Clinicians could choose IVC filter or no IVC filter. You could see that they followed a small number of patients here. But quite interestingly, they found a statistically significant effect on 90-day survival with use of an IVC filter. And the reason this is so interesting is this is really one of the few studies that's ever shown of a survival benefit in the venous thromboembolism world. Surprisingly, we have little evidence of mortality benefit on even extended anticoagulation, but we did see it with the IVC filter in this registry. So it's very thought-provoking and interesting. If we look at the best RCT we have for IVC filters, it comes from the French, the PREPIC study by Decousis. And you can see here the cumulative hazard ratio graphs for pulmonary embolism, which is labeled A, and DVT, which is labeled B, and you see this interesting mirror image effect. If you've got a filter, you're about half as likely to get another PE in the future as if you don't have a filter. The prime cost of that, though, is if you have a filter, you're almost twice as likely to get another DVT as if you do not have a filter. So, like many things in anticoagulation and thrombosis, there's a fairly tight risk-benefit balance. It's worth pointing out that about 75 to 80% of the patients in this population did find their way back onto anticoagulation at some point in time. So this is predominantly data of people with IVC filters on anticoagulants. The outcomes may be somewhat different in people who have an absolute and permanent contraindication to anticoagulation. So what do the guidelines do with this data? For patients with VTE, they recommend against routine IVC filter use in addition to anticoagulants, and they maintain kind of the classic indications for IVC filtration, which is active venous thromboembolism in the face of a contraindication to anticoagulation, which is largely active bleeding. And they go on to make the substatement that you should start the patient back on anticoagulation if the contraindication remits over time. They don't make a definitive statement on the concept of retrievable versus non-retrievable filters, but I think most centers now use retrievable filters to give themselves that flexibility over time. I will point out, I don't have a slide made for this, that the University of Michigan performed a rather scary, or performed an analysis with a rather scary observation. They looked at their outcomes in patients with IVC filters over several year period of time, and found that there was a between 16 and 25% rate of filter fracture and fragment embolization in their filter population. I found that study frankly terrifying. One issue that's important in the Michigan experience is they only use the BARD brand of filter. So whether that phenomenon is in fact a fear in other filter types or not is presently unknown. But that observation has made me have a lot of care in whom I choose to place an IVC filter, and it's made me very careful to make sure I go back and have them retrieved when they're no longer needed, because the single largest reason for non-retrieval of an IVC filter is that the clinicians forget to send the patient back to have it retrieved later on. Okay, so I've skipped through your area of expertise, and we'll go back to warfarin here and cover the rat poison for a little while. By the way, the plant in the background is sweet clover hay, and it was in spoiled sweet clover hay that warfarin was, well, actually coumarin was first discovered, and that was what led to the synthesis of warfarin. The advent of the new anticoagulants is going to be a real bummer because there's no really fun and interesting animal or plant stories attached to any of the new ones. But alas, that's how it is. So in terms of how you initiate warfarin, there's several approaches to an initiation dose. You consider this kind of an audience response question, so as you look at the options, think about what you might choose. So you have a patient with a new DVT, let's say. What are you going to give them on day one? 5 milligrams? You're going to give them 10 milligrams? Are you going to give them a dose calculated using that regression equation, or maybe do you like that regression equation better? I point this out only to say that the evolving evidence suggests that personalized dosing of warfarin is better than fixed dosing, and that evidence continues to evolve. So you can either get a good calculator and keep it handy if you want to perform this analysis, but the easiest way is actually to use a website run by Brian Gage at Washington University called warfarindosing.org. It takes about 30 seconds to put your patient information here. It'll do that calculation for you and give you a nice rational starting dose for your warfarin. If you like to continue to get guidance, you can actually keep putting in the INRs for the first 11 days of treatment, and it'll keep giving you titration suggestions. So that's really, I think, become an easy solution to starting the warfarin dose. Interestingly, our 67 or 68-year-old drug is at the forefront of genetically tailored medicine. How about that? So a lot of the work of pharmacogenetics has actually gone into warfarin dosing. This slide is a cartoon showing how pharmacogenetics play out when you look at warfarin dosing. I won't bore you with all the biochemistry, but I will just point out that this enzyme is the most important enzyme in warfarin's elimination pathway from the body. So this really determines what a given individual's half-life is. This haplotype complex has to do with the efficiency with which the body uptakes, utilizes, and reduces vitamin K. So this has a lot to do with how much warfarin it takes to move the INR initially. And then this is minor elimination pathway that may contribute a few extra percent to the warfarin dose analysis. So we can actually perform these two genotypes or these three genotypes, and by performing those analyses, we may be able to refine our dose estimate for warfarin by as much as 50%. So what's the ACCP think of that? Well, they don't think much of that yet. They basically suggest that this not be done until we get better data suggesting that it's beneficial. And when a treatment guideline says that they're waiting for a study to prove benefit of warfarin pharmacogenetics, they're usually referring to the COAG trial. I'll be able to tell you a secret since I'm on the steering committee of the COAG trial, and that is that we're very slow enrolling, and we won't be done till April 30th. If you look up COAG in any review article, you'll see that it's supposed to be done by December 31st. Alas, that's not true, but I expect by the end of 2013 the results of this trial will be available. And we're busy trying to make it happen. In fact, we enrolled our 110th patient at our facility just about 2 hours ago. So we're trying to get this done, and we should have better information about pharmacogenetics in the next year. Okay. Another important thing is you think about dosing warfarin is to have an assessment of how likely the patient may be to bleed once you start anticoagulation. And of several risk assessment scores that are out there, the best one so far is the Has Bled score, which is displayed for you there, and you see the citation down at the bottom. And you can see that it's pretty robust in determining what the annualized bleeding rate is in a patient who's starting warfarin, or even in a patient who's been taking warfarin if you have INR information already at your disposal. The guidelines largely do not say that you should choose whether or not to use warfarin on the basis of this score, but they suggest that you should perform the analysis to determine how closely you want to manage the INR and how carefully you want to watch the patient for bleeding complications. Okay. Moving on again as our stone skips into the next pond. Sorry for the strained metaphor. Let's talk about peri-procedural and anticoagulation. So this is something you guys are going to have to deal with a lot as you contemplate interventions on patients who are on chronic anticoagulation. So the problem with peri-procedural anticoagulation data is, not to put too fine a point on it, it really is bad. It's extremely low quality. There's almost no randomized controlled trials in the literature, and it's practically all expert opinion. That's in spite of the fact we've been figuring out how to interrupt warfarin for procedures for like half a century now. So far, David Garcia has got the best piece of literature out there, and he published that a few years ago in the Archives of Internal Medicine. It was just an observational study, mostly of outpatient procedures in which bridging was used in the minority of patients. That was to say warfarin was just interrupted for more than 90% of the patients. Low molecular weight in heparin injections were only given in 8.6%. Overall, in the entire population, 0.7% of patients had thromboembolic events surrounding the interruption, and 0.6% of patients had major bleeding episodes in the peri-procedural period. So quite a fine balance of thrombotic bleeding risks in this study. The one piece of useful information that did come out of this study, though, had to do with the length of interruption. So if oral anticoagulants, which is to say warfarin, was stopped for 5 days or less, sorry, there should be a less than or equal to sign there, versus 7 days or more, the risk of venous thromboembolism more than quadrupled. So what we did learn from this study is not whether or when to bridge people with low molecular weight heparin, but we did learn you really ought to only be interrupting the Coumadin for 5 days and not any longer than that. So that was very useful information from this study. So when you encounter a patient and are thinking through the concept of whether to use a bridging injectable anticoagulant or not, you really are weighing risks and benefits and a lot of uncertainties. As we think through the thromboembolic risk, we tend to think that most of the risk comes from characteristics of the patients, although the procedure may contribute some risk to that. The mirror image for bleeding risk, we think of the procedure being the important thing, although patients can have factors which contribute to the risk of bleeding as well. Other items that favor no bridging, of course, would be a contraindication to low molecular weight heparin. If the patient has a history of HIT, then obviously you're not going to bridge. And cost, if a patient can't pop the $500 to $800 for the injections, that's a realistic barrier to bridging, and it's probably a pretty good reason not to bridge. And then, of course, the patient may have strong preferences one way or the other. So what's the easiest way to approach the decision? In my opinion, you start with an assessment of the bleeding risk of the procedure. If the procedure is low bleeding risk, just do it on warfarin. Lots of procedures have demonstrated safety in this regard. Most notably, almost every dental procedure can be done this way, and most ophthalmologic surgeries can be done this way, as can skin biopsy. If you can't do the procedure on warfarin, your next question then is, what's the thromboembolic risk of the patient? If it's low, then just stop the warfarin, don't worry about bridging. If the thromboembolic risk is not low, that's when you really have to start making some decisions, and that's where you do a bridging assessment. So if we come back to the 18-9 guidelines, this is how they put it together. They look at mechanical valves, atrial fibrillation, and VTE as the three indications. In the high-risk group, they suggest that you do bridge with low molecular weight heparin, although you can see only a 2C level of evidence for that statement. In the low risk group, as I mentioned before, they suggest no bridging, and those are how these people are defined. In the intermediate risk group, then they suggest individualizing the decision. And I have to say, the more experience I've had in anticoagulation, the more and more I lean to no bridging in this intermediate group, because I think the evidence of benefit is frustratingly low. By bridging, the classic bridging is a full therapeutic dose of low molecular weight heparin, both pre-op and post-op. However, there is a split the difference strategy where you give a prophylactic dose of low molecular weight heparin and give that only post-op. And that does have some evidence supporting it. So if you want to split the difference in the intermediate group, post-op prophylactically dosed low molecular weight heparin is a reasonable option, and that would say be something like enoxaparin 40 milligrams daily. So what about timing of your periprocedural anticoagulation? So again, stop warfarin 5 days before surgery, resume warfarin 12 to 24 hours post-op, usually the night after is the way to do that. If you are using low molecular weight heparin, a couple of important timing items that have changed in the 9th version. The first is your last low molecular weight heparin dose should be no closer to the procedure than 24 hours. So a full 24 hours to let the pre-op low molecular weight heparin wear off. And then this is one that has changed substantially in 1809. If you are going to use heparin post-op, low molecular weight heparin post-op, don't start it until 2 to 3 days after the procedure, or you're really asking for bleeding otherwise. So that's a much later start than older guidelines on the post-op bridge. Okay, what about excessive anticoagulation? And this is particularly relevant to warfarin. So a nice study, this is the table of summary of effect from the 1809 guidelines that looked at the concept of using vitamin K or not using vitamin K in patients with an INR of 4.5 to 10 and no evidence of bleeding. And you can see that the risk-benefit balance of using vitamin K was pretty tight and crossed 0 in both of those instances. So not super convincing evidence for the benefit of vitamin K use in non-bleeding patients, even with rather high INRs. So how did they put that together into their evidence statement? They said for patients who are not bleeding with an INR of 4.5 to 10, they suggest against the routine use of vitamin K, and they gave that a grade 2C. So that's the difference. We're much more restrictive with vitamin K use than we used to be. So what about INR greater than 10 or the bleeding patient? For patients with vitamin Ks greater than 10.0 and no evidence of bleeding, this is when they suggest that vitamin K be used. But interestingly, at pretty small doses, just 2 or 2.5 milligrams times 1. So much smaller than doses we were used to using in the past. And note this is PO here for the route of administration. For patients with bleeding, the recommendation has changed dramatically. They now suggest 4-factor prothrombin complex concentrate, or PCC, above fresh frozen plasma. So this is a big change from the preceding guidelines. And the additional use of vitamin K, 5 to 10 milligrams, and this is administered IV in this recommendation. You'll notice the absence of subcutaneous vitamin K. There's no guideline which recommends it, and it's something that just should not be used. It causes all sorts of problems. So those of you who are savvy with your blood products will realize that there's a problem with this recommendation, and that is that we don't have 4-factor PCC in the United States. So what's a boy to do given this guideline? By the way, this, if you hold on to the recording, this can be a resource you can use for calculating a dose of both PCC and FFP. This comes from an old New England Journal article. Well, what can you do? Well, I think you can turn to a different set of guidelines, the National Comprehensive Cancer Network. You can see that there's some subtle differences in their reversal guidelines compared to those of the ACCP. But what I want to call your attention to is this recipe down here. What we do have in the United States is 3-factor PCC. And what you can do is take 3-factor PCC, combine it with a little fresh frozen plasma, and then you've essentially made 4-factor PCC, and this is the strategy suggested by the NCCN, and I think it's a perfectly rational strategy. It gives you the advantages of PCC, which is no cross-matching, no risk of viral infection, low volume, fast infusion times, and it minimizes the volume of FFP that needs to be used, because to completely reverse a supratherapeutic INR, this would be more like 12 to 15 units, which is a huge amount of volume and hard to infuse into patients and takes forever. So I think until we get 4-factor PCC in the United States, this is the next best bet. All right, we're moving on to the last phase of the lecture here. So I know it's late, especially for you guys on the East Coast, so bear with me. We'll finish up by talking about the NOACs. And I hate the term NOAC because it reminds me of that robot from the 1950s Lost in Space TV show. You know, I am NOAC. But it's actually an acronym for novel or new oral anticoagulants. So this is the phrase that covers the new agents that are coming onto market here over the last few years, and we'll be having more of those come in the next several years. So here's the coagulation cascade. I know you loved it in medical school, and I know you love it so much that you go back and review it about once a month to make sure you keep it in your memory. Ha! But anyway, I only bring this ugly cascade up to mention a couple of things about how the NOACs work. The first is that our old tried and true anticoagulants are very nonspecific in how they target the cascade. They all work at various proteins. They're all modulated by cofactors or, in the case of warfarin, reduced vitamins for their effect. The NOACs are much more targeted. Rivaroxaban and apixaban target only activated 10A, and dabigatran targets only activated 2A or activated thrombin. Another difference between these two agents and the classic anticoagulants is that they work inside, they work on their factor even if it's complexed in its activated cocoon, so to speak. So what I just circled for you there is something called the 10-ACE complex. So factor 9A and factor 7A together form an activation complex, and factor 10 sits in there and becomes activated. The old anticoagulants can't do anything once the protein is in its cocoon or in its complex. The new anticoagulants actually inactivate factors even in their complexes. So one way to think about that is they may have a really modest thrombolytic-like effect. Whether that translates into a clinical difference or not is unknown. Similarly, the prothrombinase complex is what holds 2A, and dabigatran can enter the prothrombinase complex and still inactivate thrombin even in there. So what do we know about these drugs? Here's a brief summary list, and I won't go over everything with you. Zymelatgatran was the first of the NOACs, and it never received FDA approval due to liver toxicity. So if you look at the three on this side of the column, you'll see they have a lot of interesting similarities. They are pretty similar in their time to peak drug level. They're pretty similar in their terminal half-life. They're different in their dosing strategy, and we'll go over that in a minute. And they're a fair bit different in the degree to which they're renally excreted. They also share the common feature that they have no reversal agent as of the present time, and I'll talk more about that more in a second as well. So what about coagulation testing and the NOACs? Well, the NOACs were designed not to require any anticoagulation testing. That was supposed to be their big benefit. You just take a fixed dose. You don't have to go in and get your blood tested. However, as you might imagine, there's times where you might want to know whether they're having an anticoagulant effect. So the question is, can you really determine this? And the answer is it's really hard. Of the traditional coagulation tests, dabigatran has the most reliable effect on the PTT, and I've displayed for you there the standard therapeutic concentration for dabigatran. You can see, though, unfortunately, that unlike with unfractionated heparin, the PTT response is curved, so you don't get a nice linear relationship between dabigatran level and PTT. And in fact, the PTT doesn't do much at all once you get into highly overdosed dabigatran. So it's not a real good marker of dabigatran effect. What it is useful for is knowing if there's no dabigatran on board. So this graph is of the PTT ratio. So 1 would be the top of the normal range for PTT. And you can see that if the PTT is in the normal range, there's very little dabigatran that's going to be on board. So a normal PTT is your friend. If you're about to do an emergency procedure on somebody who's been taking dabigatran, you can be very reassured if the PTT is normal that there's no meaningful anticoagulation effect on board. Unfortunately, if the PTT is even a little bit abnormal, so for our lab this would be 45 seconds, this might be 47 seconds, there could be substantial anticoagulation on board. So an abnormal PTT is not really helpful, it doesn't tell you much, but a normal PTT tells you that the drug's worn off. So at least that's something. So what about rivaroxaban? So it has a more linear relationship with the prothrombin time particularly. The problem is not all prothrombin times are born equal, and so depending on the technique your lab uses, the prothrombin time may be more or less sensitive to the effect of rivaroxaban. How that translates out is that at a given INR, if you use a sensitive agent, you may be at trough level of rivaroxaban, but if your lab uses an insensitive agent, you actually may be at high peak level and have exactly the same INR. Turns out the same phenomenon happens with the PTT as well. So depending on the lab that you have access to, the same PTT may be a trough level, maybe a peak level. So it makes it really difficult to know where you are. So the upshot of standard coagulation testing with the NOACs is for a patient on rivaroxaban, you're only reassured if both the PTT and the PTT are normal, that the rivaroxaban is worn off. You're not really informed by the level of the PTT or the PT or the PTT how much rivaroxaban is on board. For dabigatran, you're reassured by a normal PTT that it's worn off, but you can't really tell the degree of therapeutic effect. Fortunately, there's lots of lab manufacturers that are busy trying to remedy this problem, and it won't be too long before we have some meaningful assays targeted at these agents. So within the next year, you'll probably have some tests that are actually more informative available to you, but right now, you're left only knowing when the stuff is worn off and not knowing much else. So what about drug-drug interactions? I'm not going to go over this at length, but these drugs are metabolized by P-glycoprotein in the instance of dabigatran, and by both P-glycoprotein and CYP3A4 in the instance of rivaroxaban. Fortunately, the list of important drug interactions is pretty short, especially if you've ever seen a list for warfarin drug interactions. And it's ones that are pretty easy to remember because they're kind of common offenders. The azole antifungals interact with everything, rifampin interacts with everything, so no big surprise there. You see the azoles reappearing over here on the rivaroxaban list as well. And then carbamazepine and some anti-epileptics for rivaroxaban as well. The drugs I've listed in yellow are drugs in which they suggest avoidance of co-administration, or in the instance of dabigatran, dose reduction. The ones in white are potential interactors, but without evidence for clinically important interactions. So you do have to remember a few interactions, but nothing like Coumadin at least. So what about peri-procedural interruption for the NOACs? So sorry this is kind of a busy slide, and I hope you'll be able to save it for reference. I'll email Steve a PDF of this talk to pass out to everybody, so don't feel like you have to scribble notes furiously if this slide's on the dense side. The simple thing to remember is to divide bleeding risk procedures into lower risk or higher risk. For the lower risk, the rule of 1 to 2 days holds pretty well, which is to say, stop the drug 1 or 2 days before the procedure, start the drug 1 or 2 days after the procedure. For higher bleeding risk procedures, in my opinion, the 3 to 4 day rule is better. Stop the drug 3 to 4 days before the procedure, resume the drug 3 to 4 days after the procedure. That gets modified by the patient's renal function, as you can see there. This, by the way, is the opinion of myself and a synthesis of various different experts in the field. The drug labeling really leans more towards the 1-day interruption and doesn't really get into the bleeding risk of the procedure. I find the drug labeling a bit on the simplistic side, and I would be a little bit more conservative and follow timeframes that look more like this. So what about reversal? So I already showed you that table that notes there is no reversal of any of the NOACs, which is kind of a bummer. although they largely have relatively short half-lives, at least if your kidneys are working well. So that's somewhat reassuring. You can send a medical student in to hold pressure on for a couple of days, and then you're probably good to go. Sorry, that's another lame joke. But there are a few interventions that may be effective. Dabigatran is dialyzable, so if you've got the guts to put a dialysis catheter into a patient that's excessively anticoagulated and bleeding, you can at least dialyze it off. If you're within 2 hours of the last oral dose, charcoal can get rid of dabigatran at least to some degree. It's possible that prothrombin complex concentrate that I mentioned earlier reverses rivaroxaban. Most data is in vitro, and there have been studies that have conflicted with one another, so it's hard to say. More data should arise. It's unlikely that anything you're used to using does anything to the NOACs, so factor 7A probably doesn't help and is very expensive, as you know. Plasma doesn't help, cryoprecipitate doesn't help, vitamin K doesn't help. The one thing that is on the horizon is there is a late phase 2 study going on right now for a universal factor 10A inhibitor antidote that's called PRT4445. Doesn't have a name yet, but this will likely completely reverse rivaroxaban and apixaban for that matter when it hits the market, but it's probably a couple, 3 years away at the soonest, the way things are going. So if you were to kind of put together what you do with the bleeding patient who's on a NOAC, you can categorize the patient by how bad things are. For mild bleeding, hold a couple of doses, get the bleeding under control, use topical therapy if it's in the mouth, that's more for dentists, and then get the patient back on the drug. If it's moderate to severe, stop the medication, do everything you can at the local site to stop the bleeding. If that doesn't work, or if it's life-threatening bleeding, consider hemodialysis if it was dabigatran, consider PCC if it was rivaroxaban. If it's really hitting the fan and you don't mind spending some money, try recombinant factor 7A, but again, there's no evidence that it's beneficial. So what about clinical trials in venous thromboembolism for the NOACs? I'll cover the trials for dabigatran and rivaroxaban. Again, a busy slide, and I don't mean to burden you with all the details on there, mostly to show that 150 BID of dabigatran or 15 BID of rivaroxaban for 21 days followed by 20 milligrams daily was compared to usual care low molecular weight heparin plus warfarin. You can see that the patients were fairly comparable in their characteristics. The primary efficacy and safety outcomes were fairly similar, although dabigatran included acute coronary syndrome and liver function test monitoring. And you can see in summary that the NOACs were non-inferior to the comparators of low molecular weight heparin and warfarin. If you actually look at the efficacy and safety outcomes, they're displayed for you here. So the darker red is dabigatran, the pink is enoxaparin, transition to warfarin. You can see very comparable amount of recurrent VTE, very comparable amount of major bleeding in the population. If you look at rivaroxaban, very similar, very comparable amount of recurrent VTE. The trend favors rivaroxaban, but it wasn't statistically significant. And safety-wise, there's no yellow line there because that rate was 0, but again, not a statistically significant difference. So if I were to summarize, dabigatran and rivaroxaban are basically non-inferior to warfarin and enoxaparin, both for efficacy and safety. Breaking news, you timed this lecture right. If I had given it on the original schedule, I wouldn't be able to tell you this, but now I can, because on Friday the FDA approved rivaroxaban for treatment of DVT and PE. So this is actually now on-label therapy as of the last, 5 days. And finally, I'm going to finish up by very briefly covering comparative effectiveness data. My first statement is there is no comparative effectiveness data because ain't nobody's paid for a trial comparing one NOAC to another. But the statisticians have busted out some interesting tools that I'll go over with you in just a second. So broadly in atrial fibrillation, just want to give you the base rates of everything. For dabigatran, the stroke rate per year was 1.11%. The bleeding rate per year, 3.11%. For rivaroxaban in the ROCKET-AF trial, about 2% and about 3.6% for apixaban in the Averroes trial, 1.6% for stroke, 1.4% for major bleeding. And these are all compared to warfarin. If you look at some indirect comparative effectiveness research, some groups, particularly in Canada, have done some work called network meta-analysis that uses some statistical models to try to compare interventions across different trials. And they've come up with a few interesting findings. The first is that to prevent one stroke using any NOAC versus warfarin takes 131 patients. So kind of a modest number needed to treat at best. If you want to prevent one anticoagulant-related intracranial bleed using NOACs instead of using warfarin, the number needed to treat is 149. So again, not a huge number needed to treat, but a modest number needed to treat compared to warfarin. So what about comparing these guys to one another? So the scale down here is rivaroxaban versus dabigatran 150, rivaroxaban versus dabigatran 110, and you can forget that dose because it's only available in Europe and Canada, not in the U.S. This is apixaban versus dabigatran, apixaban versus rivaroxaban. And you can see three things of interest come out. The first is, to prevent strokes, dabigatran is actually better than rivaroxaban according to this network meta-analysis. The second is, apixaban is safer than both dabigatran and rivaroxaban according to network meta-analysis. So if you put everything together, apixaban, which isn't out yet, is probably going to be the belle of the ball. It's as effective and safer than its competitors. In my opinion, dabigatran is the first choice for stroke. Apixaban, when it comes out, will be the first choice for everybody unless it's contraindicated. And rivaroxaban, its only merit is really that it's a once-a-day medication. So how did the guidelines put this together? Well, the guidelines came out in February, and so they don't have all this data in their background. But at that time, they got to the point of saying they suggest that dabigatran be used over warfarin for atrial fibrillation, and they made no statements about NOACs versus one another, nor NOACs for any other indication. So in summary, dabigatran is approved for atrial fibrillation, I should say non-valvular atrial fibrillation. Its dosing in the U.S. is 150 BID or 75 BID in renal dysfunction. This dose has never been studied in a clinical trial. It was only based on pharmacodynamic modeling, and I would never personally use it. When it gets around to a VTE approval, you'll have to use low molecular weight heparin as you get the dabigatran started. Its assessment, as I mentioned, is complex, but a normal PTT excludes meaningful anticoagulation. There's no antidote, but it is dialyzable, and charcoal can be used shortly after it's been swallowed. For rivaroxaban, it's FDA approved for atrial fibrillation for treatment of venous thromboembolism. That includes DVT and PE as of 5 days ago. And I did go into this, but also orthopedic prophylaxis. Its dosing is 20 milligrams once daily for atrial fibrillation, 15 milligrams twice daily for 21 days, and then 20 milligrams daily for VTE. And then the orthopedic dose is 10 milligrams. By the way, this is why rivaroxaban does not require an injectable anticoagulant when you start. They kind of understood the nature of VTE and realized you need a higher dose at first, and then you could drop to a more of a maintenance dose. And so that's why no injections are needed with rivaroxaban. That's pragmatically going to probably give a really quick uptake because people hate their shots. The assessment is specialized, as we mentioned. If you want to make sure it's not around, it's probably best to get both a PT and a PTT and make sure they're normal. There's no known antidote. You could consider using PCC, and again, there is an antidote in the works, but it won't be out for a few years. So with that, I will wrap up. Just to mention that after half a century, we finally do have new oral anticoagulants. I just reviewed the approvals for you a minute ago, and expect to see apixaban within calendar year 2012 for atrial fibrillation. It should be out any time. These agents are broadly similar in safety and effectiveness to standard anticoagulation, but they're more convenient. However, they do have their drawbacks, and a knowledge base is required when you use them, so make sure you take appropriate care with patients on the NOACs, especially regarding periprocedural interruption and changes in renal function. And with that, I am done, and I'm more than happy to answer any questions.
Dr. Stevens, thank you. That was terrific. Very up to date, obviously, and very relevant to what we do. I did have one question for you. You know, one thing that it's a pretty common scenario is that a patient will get called saying that the patient has DVT all over their PICC line, for example. And we'll be asked to not only pull the PICC, but reobtain new access for this patient. I guess, you know, I saw your recommendation on there that these lines remain in place. Is that, I guess my question is that because of the risk of embolizing the clot there by pulling it, or is it more because it's equally effective to treat it with and without the line in place? Do you happen to know?
Yeah, there's very little evidence on the risk of causing an embolus if you pull the line. And in fact, there's some background text in the guidelines that say we don't know if you don't need the line anymore and you're going to pull it, we don't really know if you should pull it right away or wait for a day or two on anticoagulants before pulling it. But then they go on to say we mostly pull them right away in our practice. The issue is really the effectiveness of treatment. Once the patient's anticoagulated, there's no reason not to leave the line in place because the anticoagulation treatment will be perfectly effective. And if you pull it and the patient still needs access, not only do you run the risk of precipitating thrombus in a new location potentially, but now you're stuck with the problem of obtaining new access in an anticoagulated patient, which is obviously no fun. And I have to say that that issue has extremely broad agreement across other guidelines. The National Comprehensive Cancer Network says exactly the same thing. They say if you need the line, leave it in place until you're done with it and then remove it. And the British Thoracic Society guidelines say the same thing. So while there's no randomized controlled trial out there, you have very, very strong support from multiple guidelines to say, hey, you can just leave that line there, just start your anticoagulants, pull the line when you're done with it, and then stop the anticoagulants 3 months later.
Okay, that's very helpful.
Dr. Stevens, I had a question. You were talking about periprocedural interruption of heparin with regard to surgery, and you're saying, I believe, that usually you stop at 24 hours before you do the surgery. You know, when we do the catheter-based interventions, oftentimes we do that, you know, we only leave like 4 hours or 6 hours. Are there guidelines with regard to catheter-based versus, you know, surgery type of?
I'm sorry, I may have misspoke. That refers specifically to low molecular weight heparin, not unfractionated heparin.
Oh, I see.
Yeah, unfractionated heparin, 4 to 6 hours is the usual time. Yeah.
Okay.
I guess one other comment I would make, not necessarily a question, but it's, you know, for those of us doing what we do, I think we see a lot of benefit to some of the catheter-directed thrombolysis treatment. It's frustrating, the lack of data out there, and I'm glad you highlighted that. I kind of see that as a call to action for us. I think, you know, we see the benefit in some of these patients with extensive DVT, but it is frustrating with the lack of evidence we have on it.
Yeah, you know, and there is a big, I think it's a 28-center RCT going on right now, and I think that they're about 85% enrolled. I'm blanking on the acronym for the study right now. So I don't think it's going to be long till we get good data. My personal opinion, stepping away from the guidelines, is I'm convinced that catheter-directed thrombolysis and or pharmacomechanical thrombus reduction, you know, whichever technique that you favor, definitively causes much more rapid symptom improvement compared to anticoagulation alone. I think the historic 11% bleeding rate that came from the Comarota registry is archaic and relates to techniques that we've long since outgrown. So I think the bleeding risk is much lower than that. What I don't know is whether interventional therapy translates into a lower risk of post-thrombotic syndrome down the road when all is said and done, which is to say I don't know whether the anticoagulation people eventually catch up over time, but my hunch is they probably don't. So over time, as I've gotten more and more confident in our local interventionalists, have been sending more and more patients to catheter-directed thrombolysis And I think the evidence is going to bear that out, that it's going to be an increasingly important part of our armamentarium. I think what we need moving forward is a better system for predicting bleeding risk.
Yeah.
So that'll be nice to have, because it would be nice to know in advance, you know, who really is at high risk of bleed, specifically due to the intervention. Because one nasty thing about bleeding is it kind of begets thrombosis. So what happens is you intervene for thrombosis, a bleed occurs, then you have to stop anticoagulation, and then they get worse thrombosis, and then you're worse off than when you started. So if we get an effective way to figure out the high bleeding risk patients and get them out of the picture, I think that's going to be a huge pathway forward for interventional therapy.
Mm.
But I use it quite frequently. I would say I have one of my patients undergoing interventions, you know, a couple of times a month.
Huh, interesting. Well, let me see if anybody else has a question, but that was fantastic. Let's see if anybody else wants to chime in here. Okay, well, like I mentioned, Dr. Stevens will, for those of you still tuned in, Dr. Stevens, I think we do have this recorded. He was kind enough to let us record this, but he will send me a PDF version of this, so anyone interested in using these tables for future reference, you can email me. And I put my email in the comments there below.
Great. Thanks a lot, Dr. Stevens. We appreciate it.
Oh, my pleasure. Thanks for inviting me back, and happy to come again in the future if I didn't bore you too much.
All right. Hey, thanks for moderating the session, Steve.
Have a great night, everybody.
Hey, you too. Thank you.
Thanks.
Good night.